who is a nutritionist and gained approximately 20 years of experience in this field. She holds an MSc in nutrition from Bangladesh and an MPH and PhD from the Netherlands. Currently, she is appointed as an assistant professor at North-South University in Bangladesh, as well as Fong Nguyen. She's a senior research fellow in IFPRI's Nutrition, Diets, and Health Unit, and leads evaluations on maternal and child nutrition, including Alive and Thrive. Her research spans Bangladesh, Burkina Faso, Ethiopia, Ghana, India, and Vietnam, using impact evaluations, mixed methods, and costing analyses to inform nutrition policy. At this time, I'll invite Fong to give opening remarks before we proceed with the presentations. Thank you very much.
Thank you, Julie. Good morning, everyone. We welcome you to this section. This focus on accelerating progress in addressing micronutrient deficiency. We are delighted to have you here as we explore some of the most innovative and evidence-driven research shaping the future of nutrition program across South Asia. Although our presenters come from different contexts, India, Nepal, and Bhutan, their work is united by a common goal, turning evidence into action at scale. Today's presentation span a broad spectrum of solutions from digital innovation to policy transition to implementation research and large-scale supplementation program. All of them aim to close persistent gaps of anemia, micronutrient deficiency, and undernutrition that continue to affect women, children, and adolescents across the region. A key theme that ties these initiatives together is the power of integration and collaboration. We will hear how government, development partner, community, and health system are working together, and how digital tools, supply chain strengthening, and coordinated policy process being leveraged to improve service delivery and research populations that are underserved. Throughout the section, you will see the example of innovation, policy leadership, and rigorous research, each offering a lesson that extend far beyond the setting they were developed. As you listen, I encourage you to pay attention to the common challenge they address, the coverage gap, the supply chain barrier, the adherence, and community engagement. And importantly, how each team has approached this issue with creative, practical, and evidence-based solutions. With that, let's begin our section. Our first presenter is Nitish Khanna, who will share a data-driven digital innovation, the D4 mobile app designed to streamline and strengthen anemia control under anemia Mubarak in India. So the floor is yours.
So namaste and good morning to one and all present here. First of all, I would like to thank the funding partners for their generous support throughout the conference. So let's begin. The presentation title is Bridging Data and Action. The T4 stands for Test, Treat, Talk and Track Mobile Application for Evidence-Driven Implementation of Anemia Mukt Bharat Program. So myself, Dr. Nitish Khanna, I work in the Technical Support Unit of Anemia Mukt Bharat at Institute of Economic Growth, New Delhi. So as you all know, anemia is a condition in which the number of red blood cells or their oxygen carrying capacity is insufficient to meet the physiological demands of the body. According to NFHS data of the National Family Health Survey, 58% of children aged 6 to 59 months, 59% of pregnant women, and 53% of non-pregnant women are currently suffering from this disease. Let's have a brief about what is Anemia Mukt Bharat. So Anemia Mukt Bharat is a flagship program that was introduced in 2018 by the Ministry of Health and Family Welfare, Government of India. It uses a 6x6x6 strategy, that is 6 beneficiaries, 6 interventions, and 6 institutional mechanisms. To implement the AMB strategy at the camp, it follows a test, treat, talk, that is the T4 model, which is testing using digital hemoglobinometers to record the participant hemoglobin levels, treat distributing iron and folic acid tablets and managing referral cases, talk counseling individuals on the importance of iron-rich food for preventing and treating anemia. Lastly, is a track monitoring individual progress and camp outcomes to effective implementation of the program. So this is the, in detail, what are 6 interventions, what are 6 instrument mechanisms, and what are 6 age groups under the Niyamuk Bharat program. So what was the need to develop this innovation or the application? So the core problem was that lack of real-time tracking, which means despite approval for point-of-care testing using digital hemoglobinometers and full funding support, the program lacked a real-time detailed mechanism to ensure uninterrupted follow-up and tracking of beneficiaries. The test, treat, talk model hindered by the absence of an integrated system to reliably capture testing volumes, classify anemia based upon their severity, monitor beneficiaries to referral, treatment, and recovery. So the solution introduces the first of its kind digital platform under the Niyamuk Bharat program for real-time tracking, monitoring, detailed reporting, and automated tracking of severe, moderate, and mild cases of anemia. So now let's talk about the innovation in brief. So innovation is a digital platform, as you can all see, enables the real-time beneficiary tracking, monitoring, reporting, inventory management, and community dissemination of IEC to strengthen prevention, treatment, and overall program efficiency. Originally, it was piloted at T3 in Jharkhand. The user-friendly platform has evolved seamlessly to integrate all the 4 components of T4 under the Niyamuk Bharat program. So testing, streamlined anemia screening and diagnostic support tools, treat offers comprehensive treatment, information and healthcare facility directories, track, enable systemic monitoring of hemoglobin status and treatment progress using IFPRI supplements, FCM, IV sucralose, as prescribed by the Government of India Niyamuk Bharat guidelines. Talk delivers targeted awareness about anemia causes, prevention and management strategies. So core features and capability supports a diverse users including ANM, RBSK medical team, staff nurse, lab technicians, CHO through secure role-based access control. Enable real-time data management across all the target population with integrated testing and treatment protocols, advanced follow-up tracking, and automated alert systems. Provides real-time inventory management information, monthly progress reports with analytics, dashboard, and comprehensive counseling resources at multi-level administrative monitoring capabilities. So what was the objective behind developing this innovation? Firstly, establishing a robust database of ANM beneficiaries across diverse geographies and age groups, strengthening data platforms to enable instantaneous data collection, analysis, and dissemination, improve case tracking through regularly monitoring progress reports and systemic follow-ups, facilitating information, education, IEC materials, and sharing through accessible digital platforms, supporting effective management and supply chain for anemia interventions. Now let's talk about the methodology. First is the preliminary data and protocol development. The innovation represents a demand-driven model emerging from direct collaboration with Jharkhand state government and was successfully piloted in 2021 using comprehensive state population data. Through repeated refinements based on stakeholder feedback, the application achieved the full state implementation in Jharkhand in 2022, demonstrating seamless integration with existing public health systems. The success was disseminated through government forums, leading to formal scaling requests and implementation in Uttarakhand this year, January 2025, with the Chief Minister personal launch on 9th January. Based on demonstrated effectiveness, both state and comprehensive feedback, the Ministry of Health and Family Welfare has now expressed formal interest in nationwide adoption of the T4 application across all Indian states. The innovation requires a smartphone with a minimum Android operating system of 9.0 to avail all the operating features. As you can see in the top right corner, the AMB application can be downloaded from the Google Play Store by typing AMB T4 app. After the app appears in T4 in the Play Store, click on the install button and the user can accessibly use the app. So these are the other target beneficiaries which are under the AMB 6 strategy: children aged 6 to 59 months, children aged 5 to 9 years, adolescent aged 10 to 19 years, pregnant women, lactating women, and women of reproductive age. So now let's talk about some unique features of this AMB T4 application. First is the real-time status of hemoglobin prevalence. This helps the authorities to prioritize cases and monitor program efficiency dynamically. Then we have tracking of beneficiaries under treatment. Each beneficiary can be tracked what kind of treatment he or she is getting. SMS-based module may help for alert, reminder, and follow-up. This improves the patient engagement. Comprehensive evaluation of treatment effectiveness by elevating pre and post hemoglobin status before and after treatment. Identification of high risk areas, hotspots, helps to identify the pinpoint location where the severity of anemia cases is higher. Also, app can widely spread messages after beneficiary achieve normal hemoglobin levels. So what is the potential for scalability and real world impact? So as we have seen, the app has successfully deployed in Jharkhand since 2022 and Uttarakhand launched in this year by the Chief Minister. Ministry of Health and Family Welfare, Government of India has expressed interest in nationwide adoption. 14 additional states still present have shown interest. Built through direct collaboration with government officials using demand-driven models and existing public health systems. So the app has a cloud-based infrastructure, supported unlimited users without performance degradation. The app can also work in offline mode. Open AI framework, facilitating integration with existing health information systems. Existing government portals can be merged within the apps. Minimal hardware dependency on standard smartphones, as it requires a basic Android smartphone. The app can be worked on basic smartphones. So what is the real world impact potential? The app is capable of empowering thousands of frontline workers and benefiting across millions of users across the Indian subcontinent. Systematic tracking expected to significantly increase treatment completion rates, utilizing existing infrastructure to maximize return on investments while maintaining additional expenditures. So now let's talk about, in brief, how the apps look. If you see clearly, let me zoom this. You can zoom, okay. So first let's talk about the overview. After installation of the app's interface looks like this. T4 near the logo Niyamuk Bharat program. The app will prompt a screen for login. The user can create his login credentials by clicking on register. So by clicking on the register, the page appears user registration. The user has to fill his personal information, geographic information, the type of inventory the user has at the present moment. After registering, the user can see this dashboard, which represents the AMB cases: mild, normal, moderate, severe, depending upon the color code. The user can see his profile, how many cases are pending, how many cases are follow-up. Now, in the corner, you can see adding beneficiaries, test and treatment details. These are all the 6 beneficiaries that the app support. By clicking on an individual beneficiary, the app demands no need to enter the individual data. No need to enter new data. You can scan the Aadhaar card and the details can be automatically filled. You can also see the beneficiary list. Inventory management can also be supported by this app. And the best feature of this app it has monthly progress report. The user can track how many cases he or she has done, how many cases are left for pending and follow-ups, how many beneficiaries have completed the follow-up, how many have recovered. Also, the beneficiary can get their certificate for anemia testing, which is a beneficiary-specific certificate that records the personal details, the geographic details, the next follow-up details, what kind of medicine he or she is getting, and when to next the follow-up. That's all from my side. Thank you so much. I'm open to questions.
On the audience. Yeah. Thank you, Nitesh Khanna, for your wonderful presentation. It's a very relevant presentation during the era of AI. I also have a lot of questions, but we will ask the questions during our question and answer sessions. So please keep those questions in your notebook. So we are going to invite our next presenter, Susmita Paudel, from Helen Keller International. She will be talking about multiple micronutrient supplementation program in Nepal, and mainly it's focusing on scaling up and policy implementation, research, and practice. So let's listen to Susmita Paudel. Thank you.
Thank you, Chair, and good morning, everyone. It's a great pleasure to see everyone here. I'm Susmita Paudel, representing Helen Keller International Nepal. So let me start with a context. Just imagine a pregnant woman from a rural Nepal who visits a public health facility where she hears about a new supplement. And on the way back home, she stopped by in the pharmacy where she gets a slightly different message. And on discussion with her mother-in-law, she suggested her to visit to the to the private practitioner with the assumption that they will be knowing much better. And then in the private clinics, she heard a different message. So a single pregnant woman, but the confusing message across the different source. So the shifting from iron folic acid to multiple micronutrient supplementation in Nepal is not just about a policy decision, but it is a system-wide approach that we are looking into across all the province, federal, and local levels, and also in terms of all these private public practitioners. So let me take you through the journey of Nepal, how we are looking forward to transitioning from IFA to MMS. So this work actually started 3 years back. The first, and we are following the phased approach for this, and the first phase started in August 22 with a landscape analysis. And it was all about bringing the policymakers into a single table to make a consensus of whether we need to move from IFA to MMS or not. And after that consensus in a single table where we identify the system gaps and the potential benefits of moving it forward, then this phase was concluded with the consensus that we have to move forward with the implementation size approach. And now we are in the second phase of implementation research, where we are not only doing the research or generating the evidence, but also engaging with the policymakers, stakeholders, awareness, and also at the same time developing a roadmap with this evidence guidance. So our approach is interlinked into these three major approaches, that is policy engagement, stakeholder awareness, and implementation science. So we are looking this approach into the whole 7 provinces. And these all are interconnected and not being done in the silos. Evidence supports the policies, and policies guides the awareness, and awareness helps the pregnant women and the main beneficiaries to use it correctly. And ultimately, the finance is required for the sustainability. So we are looking across all these aspects in Nepal for this approach. So now let me walk you through the all these 3 approaches that I have mentioned. So in the policy in the policy level engagement, we started this discussion by bringing all the stakeholders, not only the government, but the development partners, UN agencies, academicians, and also the professional associations together in the table, where we identified and also were able to mitigate the problem that was for importing the MMS in the country because of some regulations. So that was the place from where we start this discussion. MMS technical committee was formed, and then now it's very interesting to see why the discussion or discourse is changing from why MMS is needed to how we can sustain it. So this is the engagement policy level discourse that we are having as of now. So, and also the another achievement in this 3 years for MMS is already included in National Essential Medicine List, and it's waiting the final endorsement from Ministry of Health and Population, which is also another major win. And now moving to the stakeholder analysis, we actually learned it that very early and coordinated approach in stakeholder awareness is a major important point for this success. So we engage the stakeholder very regularly, and not only at one level but across the levels. So this also helped us to create early champions who themselves were talking and convincing and discussing about the MMS agenda beyond like others major stakeholders. That is another achievement. And now coming through another whole this process was guided, and the backbone of this process was the implementation research. And this implementation research was conducted in all the 7 provinces of Nepal. So we had conducted a trial, and that is Namaste trial. In Lumbini provinces, we had almost 300 pregnant women. We had 3 arms, and then from this, we are looking into the findings of the adherence and acceptability of MMS in pregnant women. So also to supplement this trial, we have conducted a similar quantitative study named as demonstration study in 9 districts of Nepal, where we have almost 534 pregnant women taking the MMS supplement, and then we are looking into the adherence and acceptability of this product. Similarly, on the qualitative aspect, we have been talking with the pregnant women, their family members, the stakeholders who provided the service, also to know the operational feasibility of this product. Will Nepal be able to sustain if we transition from IFA to MMS? Similarly, also during this process, we have done the supply readiness assessment, where we reached the local manufacturers and also the global manufacturers to see the supply side of it, and also do the costing analysis, which will also be guiding us during the national roadmap. So, meaning this, we are now in the position that our roadmap that is underway is not just the theoretical process, but it's all guided by through all these processes that we have been taking since past 3 years. So what have we learned? So what are the lessons learned from these 3 years of durations? The early and continuous stakeholder engagement was the key, which really helped to create a policy momentum. And it's very exciting nowadays to see the policy momentum in terms of supply, system readiness, that are the prior things that need to be identified for the scale up, and also now bringing all these insights together in the roadmap that's being fed with all this information is another very interesting lessons that we have learned. So when the policy, research, and the stakeholders come together in a coordinate way early in this process of discussion, I think that's the major success for any programs to scale up. So what are the next steps? So as I mentioned before, we are already in the final stage of including MMS in the essential medicine list. So this is, we are expecting it to be endorsed in few months of time. And also the roadmap that I have mentioned is being guided by all these evidences. So we are developing a phased, costed roadmap of Nepal, so which will identify the priorities, scale-up modalities, the costing that will be required, and also at the same time we are looking into the co-financing mechanism, where at first the donors will come and support, but ultimately slowly the government will take its ownership in certain number of years to go. So at the same time, the discourse has been started for HIMS related changes that is required, and at the same time, we are also looking into the stakeholders that I have already mentioned. So with this, I'd like to, and also to know that this journey hasn't been successful at with a single hat at a single point. So I'll take a moment to acknowledge the government of Nepal at all levels, federal, provincials, locals, the main, our donors, partners, and also the trial steering committee, the research committee, and all those study participants who had made this successful. So with, I'd like to close that all these hands coming together were very, very successful, and the objective of this was to make some changes in the maternal and child nutrition sector in Nepal. So let's come together to join hands in this avenue of potential transitioning from IFA to MMS. So next year we are aiming of at least scaling up in 1 provinces of Nepal, so that slowly we'll be learning the lessons learned from that pilot province to move forward well before doing the national scale up. With this, I'd like to thank you.
Thank you, Susmita Padal, for your wonderful presentation on multiple micronutrient supplementation, particularly for the women. We may have a lot of questions. We are going to ask them at the end of the session. Now we are going to invite Sunil Kumar Maria from Evidence Action, who will be talking about the integration of private schools, particularly focusing on the children. So we had discussion about women, we had presentation about digital app. Now we are going to listen to Sunil Kumar about children's experiences from his work. Thank you.
Thank you, ma'am. Namaste, good afternoon. Co-chairs, esteemed delegates, colleagues and partners. I'm Sunil, State Program Lead at Evidence Action. It is a privilege to be here at this platform in Kathmandu. Today I'm delighted to share our experience from India in integrating private schools into the weekly iron folic acid supplementation program, a journey that offers lessons that may resonate with many of our neighboring countries working towards anemia prevention. Let me explain why private schools matter for anemia prevention. India has around 300 million school-age children between 6 to 18 years. That counts 21% of entire population. Of the approximately 250 million children enrolled in schools, out of them, 1/3 of them attend private schools. The burden of anemia is considerable. Over half of school-going children are anemic, as the National Family Health Survey reveals that anemia among adolescents aged 10 to 19 years actually increased between the two most recent surveys. And iron deficiency is recognized a leading nutritional cause of anemia. Here I would like to sincerely appreciate and give the thanks and regards to our Indian government to making such huge efforts on this prevention of anemia. However, the existing Anemia Mukt Bharat program has primarily focused on government schools and Anganwadi centers. This creates a significant coverage gap. Considering this, since 2021, Evidence Action, with support from GiveWell, has been providing technical assistance to state governments to systematically bridge this gap. So let me provide a brief about implementation strategies for private school expansion. So we used a four part of approaches in our intervention. First is the advocacy and policy alignment. We started with evidence-based advocacy to get government commitment and dedicated budgets for private school inclusion. We engaged private school associations at both district level and state levels, and also engaged policymakers on different levels to this program. We started with the pilots in a few districts, then demonstrated impact, and further with a dedicated budget allocation, we moved through cycles of budget increases. Second is the system strengthening. Under this, we mapped over 20,000 of private schools across 3 states, along with their associations and influencers and partners. We identified nodal teachers and trained them, and they become the backbone of delivery. We also established supply chain linkages to ensure uninterrupted IFS distribution. Third is stakeholder engagement. Under this, we built partnership with private school associations, private school chains, and education boards. We developed IC material made significant for private schools context. We created consent processes, which includes also school diary notes and FAQ documents for parents. Along with that, we also provided FAQs to program managers across level, which was a significant contribution to this program implementation across levels. District collectors made appeals to parents and schools. Building parental trust is essential, but we had to earn it. The fourth is rollout and institutionalization. So integrated with existing government reporting system, which was the paper-based to now is going to transfer in digital formats. Fixed day distribution moved with enabled review mechanism, government-led district collectors to true institutionalization. Let me talk about the scale and context. So on this scale and context, the program was implemented across 3 diverse Indian states, Haryana, Madhya Pradesh, and Uttarakhand. This diversity demonstrates the model of adoptable across, not dependable on one specific context. In terms of scale, we covered 43 districts out of 83 total districts in these 3 states. We reached 242 blocks and 20,000 private schools. The reach is substantial. 3.2 million school-going children grade 1 to 12 are now receiving weekly IFA supplementation program on a regular basis. This represents about 16% of private school enrollment in these states. This includes 680,000 adolescent girls as well. I'm particularly proud to share here with you all that the starting from a pilot in 2 districts in the program has been expanded across the state, and now it is being implemented across 13 districts in the state, and this is a significant policy milestone. Let me talk about and honest about what worked and what didn't work initially. So there are 5 key enablers for our success. First is strong governance structure. We had cross-departmental coordination between health and education departments, anchored by committed state and district leadership. Second is a strategic partnership. We build relationship with the private school associations, education boards, private school chains, and local influencers. They were functional working relationships, not a ceremonial partnerships. Third is the teacher ownership. Many become genuine champions, understanding the health impact and taking pride in their role. Fourth, system integration. We leverage existing public health system and supply chain, and as well as the monitoring and reporting. Fifth is the sustained government budgets for supplies, training, and awareness of the program. On other hand, on the barrier side, we faced variable school buying. Private schools have diverse priorities. The system wasn't initially designed to serve private schools, so there were delays in drug distribution, and that we had to systematically address. We encountered misconceptions about IFA drug itself. There were concerns about quality side effects, and even myths about the medication. Reporting was initially delayed, and monitoring was limited in the initial phases. The critical learning here, none of these barriers were insurmountable. They required persistent engagement, adaptive strategies, and systematic strengthening, but they could be overcome. What is required for scale up? So on the state and provincial governments, there are few things which is most critical. First is the explicitly of include private school in your annual budget plans. Second is allocate dedicated budgets. Third is the established joint coordination, which could be a structured governance with systematic review, a program review processes. At the national level, there are a couple of requirements. First is the national guidelines should be mandate private schools, including private school inclusion. Second is the private schools data in national data frameworks and programs. And third is building a state capacity to implement such programs across geographies and to benefit the beneficiaries. For implementation partners, whether this organization like Evidence Action or other technical assistance providers, the focus should be on creating public goods. Developing standardized tools and protocols that may country or state can adopt for their context. Building sustainable district level ownership and as well as capacity through systematic training, and create knowledge sharing platforms to learn from each other's success and failures. While these structures will look like different across countries in South Asia, the core principle of government ownership, cross-sectoral coordination, and sustainable capacity building remain universal. On this, the lessons we learned from this pilot and expansion. It is more important to think that at a scale implementation, government integration is feasible as 3.2 million children across diverse contexts reached under this expansion. Private school integration is scalable and is absolutely doable. Second, private school requires different engagement strategies and approaches than the government school. Private school have different policies and different structures. Third, building trust take time but pays dividends. Fourth is the level of institutional engagement and sustainability. On the fifth, convergence is core successful programming, and the last not least, the private school coverage gap is only possible. It is essential for universal coverage. At the end, I would like to thanks to everyone to having this engagement and listening patiently. Thanks a lot. Thank you very much.
I hope you are enjoying the session. Thanks for your wonderful presentation, Sunil Kumar Mayura. Now we are going to have a presentation on balanced energy protein supplementation, and the impacts of that supplementation on birth outcomes. And the presenter will be Tezring Pema Lama. She's the country director from Johns Hopkins Bloomberg School of Public Health, and she will be sharing her experiences in context of Nepal. We are very much looking forward to your presentation.
Thank you, Barnavi. Good morning, everybody. So I'm Tsering, and I will be presenting on behalf of my colleagues from Johns Hopkins Bloomberg School of Public Health. I'm going to be sharing the findings of our community-based randomized controlled trial that we did in rural Sarlahi, in a rural district called Sarlahi in Nepal. And it'll be on one of the primary outcomes, which is looking at the impact of the supplement, which is a fortified balanced energy protein supplement given during pregnancy on the birth outcomes. So a little bit of background context is that we know that poor maternal nutritional status, as indicated by the diagram here, with women being low BMI before preconception, as well as having short stature due to their own childhood undernutrition, and low gestational weight gain and micronutrient deficiencies are determinants of low birth weight babies in LMICs. And this is associated with infants being low birth weight, infants being having high infant morbidity and mortality, as well as having poor development outcomes. And in 2016, the World Health Organization recommended balanced protein energy supplements in the guidelines to be used in undernourished context, because there is some evidence that this type of supplement could improve stillbirth outcomes and reduce stillbirth outcomes in small for gestational age infants. But there is a lot of limitations in the research that was done in the past. A lot of the supplements, they varied in terms of the form, the format, the nutritional composition of those BEP interventions varied a lot. So it hindered the scientific consensus and programmatic experience on this supplement as an intervention. So in the same year, Gates Foundation had convened a group of experts where they called them together to develop specifications for the nutrition composition for this balanced energy protein supplement, both the macronutrient as well as the micronutrient. And this was convened, there's a report on it, you can find it online, and they decided to also recommend to do, evaluate the efficacy of such a nutrition BEP supplement in a ready-to-use packet, and looking at its efficacy of this intervention on birth outcomes, especially in settings which has high rates of undernourished pregnant women. And one such setting was selected for the trial was Nepal, and it was our research site, which is in Sarlahi district. It's in the south of Nepal, and this is just some data from like past pregnancy cohort. You see that the population that we work in Nepal has it's a highly undernourished population, and we have high rates of small for gestational age and low birth weights. So the objective of the study was to conduct this community-based randomized controlled trial to test the efficacy of the daily fortified BEP supplement when given during pregnancy as well as postpartum. And it had two primary aims, looking at its impact on birth outcomes. The birth outcomes is the one that I'll be presenting on. The outcome was incidence of small for gestational age, and then the other one is infant growth outcomes. And the study design, as you can see here, it's a 2x2 factorial household randomized trial that we did. We enrolled women early in the pregnancy from November 2021 till August 2023. It was a long longitudinal RCT. Our sample size was 1,800 pregnancies to get around 1,600 live births. And we did it in Sarlahi, in 2 rural municipality and 4 municipalities. So the intervention, so the control group as well as the intervention group got the standard of care, which is they were asked to go for their regular antenatal care checkups in the nearest health facility, as well as to go to a birthing center for delivery. And they were counseled on that. They also got counseling on nutrition, hygiene, and infant young child feeding. They were also given a clean birthing kit in the instance that there is a home birth that occurs. And if they did not receive albendazole and IFA tablets from the ANC visits at the facility, sometimes there's shortage of tablets, then we provided them. If not, they were asked to take it from the ANC visits. The intervention group got this BEP supplement, which is a ready-to-use supplement. We've done 2 rounds of formative research prior to this trial, and we've come up with this supplement being the best for the trial. The supplement itself is actually manufactured for the purpose of research by Nutriset in France, which makes a similar product called Plumpy Mum. And it's 72 grams daily sachet that they have to eat. It has roughly 400 kilocalories, 14.5 grams of protein, and it's also fortified with 15 multiple micronutrients, as well as 500 milligrams of calcium. So it's a lipid-based, like a paste kind of supplement. So the data collection procedure itself, we initially did a census. In our study area, we identified households that had eligible women, which are married women, 15 to 30 years of age. We then did a pregnancy surveillance where we have data collectors who live in the community who are female, and they do every 5 weeks they visit the households to identify if the woman has missed a period, and if so, then they do a urine pregnancy test. And once we identify a pregnancy early on, then we enroll them, we take their consent, and roughly in our study, it's around 9 weeks that we've enrolled the women in their pregnancy, and then we collect all the baseline pregnancy history, as well as household SES, food security, diet kind of questions, and also anthropometry measurements. And we start the supplementation in the intervention group from 14 weeks of gestation all the way till the pregnancy ends. And as soon as the enrollment is done, we also did home visits where we took a portable ultrasound machine and did their gestational age dating, because our primary outcome is small for gestational age, so you need a very accurate gestational age measurement. And then we had the same large cadre of female workers in the field who would do weekly visits to both the control group as well as the intervention group and give the supplements as well as collect data on adherence. And then in the late pregnancy, again, we do a very detailed assessment, asked a few questions, and also did anthropometry measurements of the women. And then once we are informed of a birth that takes place, we have a separate birth team that would go to the field and try to visit the women within 72 hours of delivery and do a birth assessment of both the mother as well as the newborn. So really quickly on the study flow chart is that we had about 16,000 women who were first eligible, and then around 4,000 were deemed not eligible. And in this study, we enrolled 1,944 pregnant women, which resulted in about 1,581 live births. And as you can see, they were randomized into the 2 groups at the time of enrollment. In terms of baseline characteristics, being a randomized trial, we see that the 2 groups are very balanced. The average age was about 24 and a half years, and about 10% it was a nulliparous, so it's the first pregnancy. About 30% of the women were underweight based on their low BMI. early in the pregnancy, and we deal with we work in an area where close to half of the women have not gone to school at all. So going to the results, the primary outcome, as you can see, is the first row. It's the small for gestational age. We did not see, and as you can see, with the relative risk for both the unadjusted as well as adjusted relative risk, we did not see an decrease in incidence of small for gestational age in the intervention group when compared to the control arm. We also looked at various secondary birth outcomes like preterm births, low birth weight, short for gestational age, and so forth, and we did not see any impact on those, but we did see slight improvements in the head circumference as well as weight for age centile secondary outcomes. And then we also looked at a few other secondary analyses. We tested for effect, we did an interaction test to see if there's any effect modification by potential effect modifiers. There was no evidence of effect modification by maternal short stature, underweight, age, education, or the infant sex or proportion of supplements, so by the adherence categories. We also saw no evidence of dietary substitution because in a subsample, we did a 24-hour dietary recall in both the control and the intervention arms, so there's no substitution in the supplementation group. There's also no difference in the incidence of large for gestational age babies, because I know that's a concern, and also in the C-section rates. And even after adjusting for covariates, as well as the clustering by household, these findings did not change. In terms of the implications, the daily fortified BEP, even though it started in second trimester, it may not be sufficient to reduce incidence of small for gestational age births in rural South Asia. In a population where there's high rates of undernutrition, BEP may provide small benefits on other adverse events, birth outcomes, sorry. And then we still have to do more analysis in terms of exploring the effect of BEP on gestational weight gain, as well as we've collected some infant and mother's stool in a sub-study. So we are now currently looking at the gut microbiome to see what is the biological mechanism as well. And future trials should explore targeted strategies. Preconception intervention is one area of interest, addressing adolescent undernutrition and integrated intervention packages. So I just want to end with this picture of the last mother and child in our trial. Got consent for the photos. I'd like to thank all the study participants, the community that we have in Sarlahi, all the co-investigators, our Nepal Nutrition Intervention Project Sarlahi team, the local partners NNGS, and the product manufacturer Nutriset. And I'd like to thank the donors for the trial, which was Gates Foundation, Trasher, and NIH. Thank you.
Thank you for your wonderful presentation in context of Nepal. I also have the experience working on BEP, so I think the findings are more or less aligned. Now we are going to invite Ugyen Wangmo from Bhutan. This is our last presentation. She is working in Ministry of Health, and she will be mainly talking about sprinkles, micronutrient powder for children below 2 years of age. And yes, welcome to your presentation.
Good morning, everyone. My name is Ugyen Wangmo, and I'm a program officer at the Department of Public Health, Ministry of Health, Bhutan. It's a privilege to be here at the Delivering for Nutrition in South Asia conference. My presentation today is on about the successful rollout of micronutrient powders for children 6 to 23 months of age across Bhutan. So before diving into the intervention, a very quick snapshot of Bhutan. We're a small country with a population of approximately 777,000. And as you can see, our health indicators are very strong. Our institutional delivery is at 98%, and the remaining 2%, I'd like to say, would be inside the ambulance or on the way to the hospital. Accordingly, we have a very high coverage of antenatal care and postnatal care. And despite being a small nation, we are deeply committed to the health and well-being of our citizens, as mandated by a constitution, to provide free access to basic health services. And we have a 3-tier delivery system, which relies heavily on our grassroots community workers. But however, even with like really strong indicators, even with strong basic services, we face the challenge of hidden hunger. So back in 2015, the National Nutrition Survey reported a significant problem in our youngest children. Specifically, we had a 4% prevalence of wasting in children under 5, 21% of stunting prevalence was at 21% in children under 5, and specifically 43% of our children were anemic. And when you look at child feeding practices, the issue really becomes clear because only 1 in 8 children were fed a minimum acceptable diet, and a mere 17% had iron-rich foods in their diet. And this gap, especially during the complementary feeding process, is exactly what the micronutrient powder or sprinkles is designed to close. And after the survey, we also found out that WHO recommends the use of multiple micronutrient supplement for point-of-use fortification, especially when the prevalence of anemia is more than 20% in the population. We also looked up other interventions into other countries' global best practices, studies, evidences, and we found out that the evidence for micronutrient powder is undeniable. MNP significantly reduces the prevalence of anemia and iron deficiency anemia with minimal side effects. This gave us the confidence to proceed ahead with the intervention. As you can see, the MNP, also called as Sprinkles in Bhutan, contains 15 micronutrients, and the packaging has also been customized to increase the acceptability in our population. Our objective, we had 3 key objectives, and number 1, it was to reduce the prevalence of anemia and other micronutrient deficiency. Number 2, it was to improve the nutrition quality in the complementary foods and to increase the dietary diversity. And number 3, to evaluate caregiver acceptance, adherence, and operational feasibility of micronutrient powder through distribution through the existing health systems. And to answer all these feasibility questions, we conducted a 3-month intervention study in 3 of our poorest districts. And the intervention study was conducted among mothers and children aged 6 to 23 months. It was conducted in 3 poorest districts indicated from the Bhutan Living Standard Survey 2017. The baseline data was collected on the day the intervention was assigned, and the end-line data was collected after 3 months. Children with SAM illnesses, children coming from other areas were all excluded. For the study implementation, we trained 2 health workers from each study sites on intervention and data collection processes. We trained 1 district nutritionist as a supervisor who conducted periodic monitoring. After the 3 months intervention study, the results or the findings were very encouraging. If you look at this chart, you can see significant gains across several key child feeding indicators. Most notably, minimum meal frequency rose from 78% to almost 90%. Minimum dietary diversity rose from 43% to 55%, and the minimum acceptable diet rose from 33% to almost 49%. So in the second graph, we see that the acceptance of MNP product itself was highly encouraging. We achieved over 95% compliance. More than 99% of caregivers thought that the sprinkles were good for their children, and 95% said they would recommend them to others. We also confirmed that over 90% of our caregivers understood the contents and the correct dosage, and it was a huge win for our training efforts. And finally, for the most important outcome, the pilot showed promising reductions in all 3 indicators of poor nutrition status. underweight, stunting, and wasting. So the implementation challenges are any key barriers, which included caregiver concerns about side effects, which highlights a need for better communication. Based on this successful pilot, by June 2020, we achieved nationwide rollout of MNP. And the key to our scaling success was integration. We didn't create a new standalone program. We fully integrated MNP distribution into our existing mother and child health services, specifically syncing it with the growth monitoring schedule. This leveraged existing healthcare contexts and simplified the process for both healthcare workers and caregivers. So this is the growth monitoring schedule that we follow at 6 months, 8 months, and 10 months, where they also distribute 1 box of sprinkles, and the mothers are advised to give them on Mondays, Wednesdays, and Thursdays. Child's growth monitoring is also done. And at 15 months, 18 months, and 21 months again. So implications for scaling and policy. Our experience offers 4 key implications for those looking to scale similar programs. We must first advocate for formal inclusion of MNPs into the National Nutrition Action Plan, making this a permanent fixture. Also, number 2, integration is paramount. Using existing platforms like the IYCF counseling and community health visits is the most sustainable approach. And number 3, continuous effort is needed to strengthen the supply chain to prevent stockouts and ensure that MNP reaches the last mile. Finally, we learned that continuous communication is vital, especially to address minor side effect concerns like dark stools that can lead to dropout if not managed through strong counseling. So Bhutan's journey from pilot to nationwide scale-up demonstrates that high-impact nutrition interventions can be integrated successfully, provided they are supported by strong policy, clear operational strategies, and a robust primary healthcare system. Thank you for your time.
Thank you for all excellent presenter. So now we start to open the floor for question. I would like to request the presenter come here with the chair. There's few chairs here. So we can bring that 2 chairs. Yeah. So we have 5 presenters, 5 chairs would be good. So we have 1 more chair there. Okay, we are great. Please come, yeah. Oh, we still need 1 more chair? I think we need 1 more chair. Can we have 1 more chair? Sorry for this. Yeah. We have 1 more. We should be happy now. Yeah.
1 more chair, please.
2 more, right? No, 1 more. I'm okay. I stand up.
When she'll be sitting, I'll be talking, so no worries.
Yeah. Do we have mic for the question? Okay. So now we open for question for the floor. Yes. Can you describe the mic? Yeah. Okay.
So,
Yes,
thank you
please.
so much. My question is to Natish Khanna. Very well presented your innovations and all the journey. Can you elaborate a little more about the compliance part? What that was the part of the application and how it went while you are experiencing the app?
Thank you. So we will take about 4 or 5 questions, and then we have round answer, and then we take another one. Okay, please. Yeah.
My question again goes to Nitish Khanna, because I'm very well familiar about this technology, but the challenge that we are feeling is one is the data protection policies. Where does the data goes and is stored, and how it is utilized in future? That is one. That is prohibiting part to go with this methodology. One hand, and another is regarding the cost. It costs around 35 to 45 INR or test. So under this context, and also this, I'm from UNICEF, Nepal, because the UN system always look very evidence-based, which is certified at the global level, and where WHO, especially any technical groups are engaged, the recommended one. So under this context, whenever we have to advocate the government, that is one of the barrier, because this kind of evidence is still not available. So because the government of the Uttarakhand also engaged in the process, so what advocacy strategy you used, and how do they convince to invest in this kind of initiative? Otherwise, this initiative is very quite
Thank
welcoming.
you. Thank you. So we take yeah. Okay.
Thank you. I'm Kritika Dikshit. My disclaimer is that I do not directly work in nutrition, so please do not mind any basic cautions. So my question is to Turing. So really interesting presentations. I would like to know that what is your takeaway by using the ready-made food among the pregnant or lactating women, or the perception from the healthcare providers, given that Nepal, they have they promote locally grown food, and there are other like nutrition programs that promote maybe local eggs and locally grown food. So what is your takeaway regarding providing the ready-made therapeutic food, and if you think that acceptability of that is higher, would you also suggest providing similar kind of food to other other vulnerable groups who are malnourished or undernourished?
Thank you. Yeah. We have that lady there. Yeah.
Thank you. So my question particularly is to Mr. Sunil. Mr. Sunil, congratulations for the wonderful presentation. Just wanted to understand that an organization, what challenges did you face while maintaining the supply chain of IFA while working in a private school setting, and who was responsible for it, and did you do anything as an organization to build capacity of people who were involved?
Thank you.
I represent an organization called CINI, so we are also working in WIFs in certain areas, so it's a wonderful expansion initiative. Congratulations.
Okay, great. We take the last question. I think we can give the floor, the mic. Yeah.
Thank you so much, and my question is to Nitish. I'm sorry for bombarding you with another question but you had a great presentation. My question is more on the application that you are mentioning. Who owns this application? Where do the data goes? And then secondly, from the presentation, my understanding is it's more with the health department of the state, but are there options available to kind of integrate the data? Because there's a lot of line listing in India that happens through different departments, through different frontline workers. So is there an endeavor of this application to bring convergence even between the departments at this level? Because the same person is being tracked by different departments for different reasons, right? So on that one.
Okay, thank you. So I think we will give the floor for answer first, and please answer as brief as possible so we can give the time for the second round of question. Yeah.
Hi, thank you for all the questions. So coming to the compliance part. So the app was piloted first in 2021 in the state of Jharkhand with approval from Jharkhand government, and it came to fully fledged app in 2022. Initially there were some challenges as there were approvals, administrative, like government approvals take time. Also the main challenge was that the frontline workers were reluctant to use the technology because they thought that their data will be lost. What if they enter double data entry? What if some data correction has to be done? So keeping all this in mind, the app is currently full-fledged in Jharkhand with a data of around more than 5 lakh users currently enrolled. And the data is completely tracked by the government of Jharkhand and the Ministry of Health and Government of India. And also we at the IG, we are also a government institution. So data is also under our control. the state government officials can continuous monitor data through the dashboard that is developed by IG only. So there is no loss of data manipulation, you can say, or data lost, or any scammer can enroll. So data is completely protected. And coming to that question of your, sir, what was, can you repeat? UNICEF. Yeah. And the cost? So the cost is less than 5 lakhs INR, as it is an in-house developed app and can be customized for any specific geography in less than 7 days.
So maybe a lot of question can be after the call for the site, and then we can give time for other presentation. Yeah.
So coming to your question, the app can be integrated and fetch data from various platforms like UWin. The only feature is that if any platform is using the Aadhaar ID or Abha ID, we can easily capture the data in the app.
Okay. Thank you.
Thank you.
Yeah. And yeah, can you? Yeah.
Okay, thank you for your question. So in terms of acceptability from the health provider side, where prior to doing our research, we did consult with them. We sort of had meetings with many A&Ms, the auxiliary nurse midwives who work in the health facilities in our study area. We made them aware that we're doing this trial, the design of the trial, even with the health coordinators in each of the municipalities. And we've included them since the very beginning of the formative research as well as the main trial. And in every year, we would just, like sort of update them on the happenings, because the women are going to the facilities to seek care, and it's good that it's for the health workers to know about the product. The only problem is, like, they keep changing. The turnover of staff is high in facilities, so we have to do more like outreach and meetings with them. And so the acceptability is there. In fact, I was just checking our data, and we also, in our one of those late pregnancy visit, we also asked them if they're taking other supplements, and we see almost like 50% of our study population, both in the control and intervention, were prescribed by a health worker, either in the private sector or the public sector, to have some kind of protein supplement. And usually it was, they had to purchase it. So, and we also have data on the type of supplement. Most of them were protein powders, and it was like Indian brands, because our study area borders India. So there's a lot of Indian pharmaceutical products that's available. And it's very rampant. They are different in quality. So there is a need that the health workers see in terms of the women being deficient in protein and micronutrients. So as you can see with MMS as well. So I don't think that is an issue. In terms of other groups, I think there was a trial done in India, the WINGS trial, which had a balanced energy protein supplement, which was it was not a ready-to-use packet, but it was like cooked meals, but with the similar compositions, and they had a preconception arm. And there is evidence that having the supplementation given in the preconception period was also beneficial. There was added benefits, but they also had an integrated approach. There was WASH, there was psychosocial counseling in that trial. So it's very, a lot of interventions were in that package. So it's hard to say, is it just the BEP that made an impact or not?
Yeah, can you make it more brief, please? Yeah.
I think that's all.
Okay, thank you.
So thank you for asking the question on IFA in private schools. So mainly on supply chain. So before coming on this supply chain, the motivating and convincing private school for such BIFS program, implementing BIFS program is really very challenging. So that was the reason we engaged to district collectors to motivate and convince to private schools. Once they convince about the program, to implementing the program, then its questions comes to the supply chain. So regarding the supply chain, we ensure the challenges was actually the one awareness about the IFA drugs, and convince them that IFA drug is safe and they can collect from a spot which is nearby in education system. Second is that the challenge was drug transportation, how the drug going to transport from education office point to the private schools. And third was the calculation and raising the demands demands once the drug has been going to finish. So these are the couple of challenges we encountered through systematic provisions in this program, and it was helped through the cluster resource centers, which is the government system in India, and it provides a control over government schools. But through this program and engaging these collectors, they also engaged to program for private schools as well. So they were the key point person for drug transportation to the private school, and they convinced to private school collect the drugs from CRC and cluster level centers. Apart from that, reporting for drug stocks for receiving and maintaining inventory, it was also challenges. So we provide them the training on that, how to calculate drug, how to stock taking the drug on your schools, and how to demand those and raise those demands. Now we are going to implement digital platforms and giving them access for that to raising the demand and also giving the status about the drug supply chain on regular basis. This is going to help a lot in this program and intervention. We piloted in one district particularly under this project.
Okay. So we answer all the first round questions, right? Okay, great. So we have a lot of hand raised up. I know that we are very interesting section and then a lot of questions are interested. Unfortunately, our time is up, but all our presenters are still here. So I will encourage you that after the section, you can go to meet separately with each presenter and you have more in-depth conversation. Okay. Now I would like to also give more applause for all our excellent presenters. Yeah. So finally, our co-chair will give few closing remarks.
You want to sit here, please? Yeah, no, please sit. Huh? Thank you. Yeah, thank you. Thanks for the questions and answers. I also had several questions, but I wanted to give you the floor, so I didn't ask my questions. But I think it was a wonderful session, and at the broad theme of micronutrient deficiencies, we have covered so many things. We have discussed about the digital application, its feasibility, the challenges to reach out to the people. I think there are a lot of issues when we talk about any app, particularly about the beneficiaries who are who have limited access to those technologies. So I think there are a lot of challenges if we really want to roll out those kind of programs. So congratulations for that, for sharing your experiences. We also discussed about multiple micronutrient supplementation in context of Nepal. For the women, we also had session on children, school-going children, children less than 2 years of age, particularly focusing on sprinkles. I was also thinking about the multiple micronutrient supplementation because there are a lot of debates also how the people actually, how the experts adjust the dosage to minimize the effects of inhibitors. So sometimes some micronutrient works as inhibitor in terms of absorption and all of that. So I think there are a lot of issues around that. Maybe we need to discuss after the lunch session or during the lunch session. But as a whole, I think it was a wonderful session, and I think your questions and the discussions also clarified the issues that we had in our mind. I think now you are almost waiting for your lunch probably. So thanks for joining the session, and thanks for participating. So enjoy your lunch. Thank you so much.